today is to talk to each other. So I will just go through them and hope that then we can pick up on them as we talk. So of course it's part two of the report based on part one, which really was a market review laying bare the problem of supply and demand. And all of you, I'm sure, joining us today will have seen and read the summary of part one. Of course, in the time between part one and part two, we've had the pandemic, and it's quite likely that the pandemic may have widened and will have widened certain inequalities and may have done so in this space. And were we to get a future recession, that, of course, I think would drive the trends and usage and deaths in the wrong direction. Part two, as you all know, is about treatment and recovery and prevention. And we examined the system in detail. We had discussed it in part one, but now we went into the nitty gritty. And simply we found it broken and wanting. And I think really government either has to invest in tackling the problems we described or continue to pay each year the 19.2 billion it costs to cope with this problem. The methodology was pretty standard, as you know. We had a call for evidence. We had some excellent responses to that. 156 responses brought together in a summary, which was published at the same time as the review. I had a really good expert reference group who kept my feet to the fire. They met jointly and they also advised me individually, and I had great help from two very special people, Professor Keith Humphreys, our international advisor from the University of Stanford, and of course, Dr. Ed Day, who's our recovery champion, who played such a very important role in particularly in the section on recovery. And then we had lots of stakeholder engagement, and probably having to do it all in a virtual sense enables us to talk to so many people online that it might have been more difficult to reach had we been trying to do this all the time in person. Just thinking about the situation that we were dealing with, and of course I'm not going to read all those comments out, but I think we can all agree that the capacity and quality of treatment had declined and had been declining for at least some 8 years, and that the prevalence of use and harm has increased. And you see in this slide the green arrow looking at the good position, if you like, that we were in 2012, and the red arrow showing the much worsened position in 2019. And it didn't matter where you looked, whether it was at adults, whether it was looking at children, everything had gone in the wrong direction. And of course, it isn't equally distributed across the country. We know that there are certain parts of the country, for example, the northeast and the southwest, where things are worse, and a sad decline in the number of people entering and completing treatment. But you know this all in the wrong direction. As I said, geographically not evenly distributed. And you can see there in this heat map, there were some areas where it was worse by 300% or more, and some where they were doing rather better. And I think we must acknowledge that in certain parts of London, there were some good areas and areas where we saw a decrease, but overall not a particularly good picture. Again, you all know, and I don't need to go into this in detail, that the funding of drug treatment and the number of people treated have reduced substantially. And if you were a non-opioid user, then your opportunities to get high quality treatment was certainly very diminished. And all of that was against this backdrop of increasing harm and widening inequalities. And you can see here that it doesn't matter whether you look at young people or you look at adults, the trends are the same. The number in treatment decreasing, and the funding for treatment of drug dependency decreasing. So everything moving in the wrong direction, which of course means we have a lot of unmet need, and we've known that for some time. So what did this review try to do? It didn't try to pick out any individual treatment or intervention. It was seeking to look at a whole system. What do we have to do to get the system to work properly? Who are the key players? What are their relationships? And then, of course, acknowledging that an additional investment is absolutely necessary. We really needed to improve the system of accountability of local areas to national government. We knew that was very important. And then local partnerships, which had in previous years worked well together, we needed to put a great deal of attention into that. The workforce demoralized and diminished, again, a subject of real concern. And of course, the idea that we needed a holistic treatment package. I do not think of treatment as just that which is clinically delivered, or even if you add on mental health or comorbidities. You all will have heard me say, and I've probably bored you stiff by saying, that in order to enable someone to really move through recovery well, you've got to have an excellent recovery system, which may take quite a number of years. And in my holistic treatment bucket, if you like, is good housing and employment support. You cannot expect someone to take this journey if they're having to live in a house where someone is shooting heroin. So you can see there on this slide, there are some things that belong, if you like, to government, clear accountability, local government and effective partnerships, absolutely government leadership from the centre. You'll find there that I put in research and science, really distressing to see how little research and science was going on and how much we needed to improve that. And then all the things that lead to a good recovery. And of course, our additional investments. And we can't run away from this need for extra funding. I think in the review, the analysts and the team have made the best possible evidence-based submission in the report that they can, that if we do these things, then we can expect a return on investment, as you will see in the end. We've been very careful to justify everything we have recommended. But if we're thinking in terms of 5 years, you'll see that by the end of the 5th year, we need some 552 million that year to be invested in treatment systems through DHSC. So it's building up from about 119 through to that 552. We of course want DWP to still be supporting employment and particularly individual placement support. We know from their trials that this is a successful way of engaging people who are drug dependent and enabling them to move towards employment. We also need additional housing, and there still is work to do with MHCLG on the type of housing that we most need for our drug dependent community. But we need to do that work before the next spending review so that a bid can be made. You will have seen in the report that I have really said that this money needs to be ring fenced. We can't just give it as unrestricted money. It needs to be ring fenced, and there needs to be real accountability at the local areas. And of course, that funding is flowing from DHSC, MHCLG, the Department of Work and Pensions, whether it's through NHS England or local authorities, to deliver what we need delivered at a local at a local level. We really must have a strong central drugs unit, because it's not that departments haven't cared about this topic or that they haven't tried to do individual projects. I believe they have, and there's evidence of this. But you need at least these 6 departments to come together. There are occasions when you will need other departments just to put in some effort, but you need a central drugs unit with the 6 departments in there, a responsible minister who will report each year to Parliament on progress or otherwise, and a national outcomes framework to which the service is being delivered. And then the minister would then report on the progress against the national outcomes framework. And from that national framework, at a local level, we would have development of a local outcomes framework. But to do that, we need to engage with the people on the ground. And so it is about some real central leadership and support. The King's Fund has, of course, helped us a great deal in thinking about local commissioning. Of course, I'm not going to read this slide out to you. I won't say that it wasn't without debate and real thinking through about where the commissioning should be. But you will have seen from the report that we decided that commissioning at the moment was best with the local authorities. And if you think about the very holistic service that we need, the period of recovery and all that goes into recovery, the housing, the employment, that it was best left there, but absolutely with accountability to the centre and with ring-fenced funding. So expectation, real expectation of local delivery. We also thought the new integrated care systems that are coming into place could be of real support as we move forward. Well, we want good relationship between central cross-government, the drugs unit, and local authority, and the health and the criminal justice partnership. And you can see there some of the relationships, how that national outcomes framework should relate to local outcomes framework. And I've said, and I'll say again, it must be developed, that local framework, with those who are working in the system so they own it. And then it can be used by the new Office for Health Promotion to hold local authorities and other relevant local agencies to account. One would like to see a joint needs assessment, and then if possible some joint commissioning, so that we can really start to get a really coordinated system working, which really benefits all the needs of those who are indeed drug dependent. I wanted to make sure we put the individual at the center. This is about an individual with a need, and they may require any of the circles that I've put around the individual. They may not need them all, and their needs may vary across time, but you can see quite clearly that requires our 6 departments of state. And all I would say to you is that if we start lopping bits off, so let's say we decide we don't need housing and support and maybe mental health care, you don't get anywhere near as good a result. We have got to accept that this has to be joined up with all these relevant players. And if you think you can start nibbling at the edges and just take one out, well, you'll get a diminished return. We have never done this together in a coordinated and determined way. As I say, bits of it have been done. People have talked about the need for housing, and they've talked about the need for employment, and of course the need for mental health and trauma care. But this is saying it requires it all and it requires those 6 departments of state to be there for the long haul and to be part of the central unit. I learned a huge amount about recovery as I did this review, and as I said, I owe a great deal to Ed Day, and I learned that recovery has to be at the time and speed of the individual who's coping with their drug dependency. That could be a year or two, it could be much more. We recognize entirely that people with lived experience have a crucial role to play. We really found them to be a very strong, and they made such a positive impression on us as we were doing the work. But we don't wish to see them exploited or used as cheap labor. And we were very aware of the value of small grassroots organizations, and they may be particularly valuable for vulnerable groups who require special attention. So, as you know, we have made recommendations in this area, and I just would draw your attention also to the need to look very closely at residential rehabilitation and inpatient detoxification, which of course suffered a lot, needs reform, and one needs to consider how would it best be delivered. Is it on a regional, or would it even be worth considering a more central approach to that? Probably the area that gave me the biggest headache, because I really was so upset to see how people were dealt with as far as their mental health problems were concerned. It seemed to me that if you had a mental health problem and you were drug dependent, it was almost impossible to get the two things dealt with as if you were one person, rather than two different individuals, and being told you must cope with one before you could get the other. Of course, we never say to a person who's got breast cancer, well, we can't really deal with that till you've got your hypertension under control, get the blood pressure under control, then we'll think about your breast cancer. You know, a medic would be struck off the register for that. You can't do that. Why do we do it to people who have a drug dependency problem? We all recognize that trauma and mental health are an accompaniment, and indeed may lie right at the heart of much drug dependency. And if you can't give help here, it's going to be very difficult for individuals to stop their particular drug. And we all know that people fall between the stores, and so much time is wasted when we need to get these problems addressed together. And this, of course, is a local issue. And we do require NHS England and DHSC to really work together on how to sort these mental health needs out, and to make sure that the contractual requirements, or indeed to consider whether incentives should be introduced. So mental health is integral and central to drug dependency. Employment has been something that I've been really interested in, probably since doing a review in 2016, which gave rise to the individual placement support. 7 centres, a randomised trial run so efficiently by Public Health England, with DWP being the department that commissioned this. And it has shown, although we haven't yet got the published results, that you can indeed get people back to work. And if you can do it and do it through treatment centres, and you have your caseworker really working with the local employers, then you can do the most remarkable things. And in the first part of the review, I visited prisons and treatment centres and charities, and in talking to people who were either trying to come off drugs or had come off drugs, they told me there's a big black hole when you're clean. You need something meaningful to do. And of course, work does provide something meaningful to do, and it can build self-esteem. So for me, it is a really important part of the offer. And if people are left with nothing to fill those very long hours, it is quite easy to go back to your old way of life. So the recommendations there were very much directed um, to DWP, with whom we've worked very closely throughout this review. And then, as I mentioned earlier, many people with a drug dependency either have an urgent housing need or they have a housing problem. It is bigger, a more sort of urgent for those who are opiate dependent, but is not exclusive to that group of individuals. And as you all know, drug dependency could be a cause or a consequence of homelessness and rough sleeping. And having a healthy home is so key to recovery. But as we all know, local authority housing services at the moment do not systematically provide specialist housing support, yet we do know of good initiatives, as I've mentioned there, that have been working well. So we need MHCLG and DHSC to work together urgently, really, in the next few weeks to really work out the types and level of housing support that people with substance misuse need, and then to make sure there is an appropriate bid put in to the next spending review. I mentioned that we have a paucity of the workforce, and those that are there are really demoralized and feel really neglected. You can see how few psychiatrists, psychologists, other doctors, social workers, and pharmacists we have got, and all those groups need attention. And you can see that there should be one consultant psychologist per local authority. That would be about 150 of them. We currently have 51, just to give you an example. And for drug workers, they should not be looking after more than 30, 35 cases at any one time. That should be their caseload. The average is 50, and in quite a few cases, it rises up as high as 80. You cannot do a good job if you've got 80 people to look after. That translates then into people not being satisfied with treatment, leaving treatment, or not thinking it's worth even going into it. So a big piece of work to be done with Health Education England on the workforce. You will have noticed in the report that young people have fared rather badly in the last few years. We've got a 40% increase in drug use in children, and there's a whole variety of drugs that children have used in the last year. So this is a big topic, and we need to put in prevention and support, and that may become, we've worked with the Department of Education to see how we can support what teachers are doing out in schools as they roll out their recreational, sexual and health education. And of course, there are things which don't have to be just directed at the problem of drugs, but things that support children, whether it be youth clubs, things that are there in a more general sense for after school activities, but very, very conscious that young people have suffered a great deal. And then there's a section, of course, in the report on prison. A third of our prison places are taken up by individuals who have a drug problem. We know that for some people, rotating in and out of prison, perhaps for 4 months, is not helping at all. Indeed, it may be that they meet new drugs such as spice, which perhaps they haven't met before. Their families might be got at by drug gangs where they've got at the person in prison, and then the gang has contacted the family outside. There's little rehabilitation. And if we can, as we recommended in the review, see a much better diversion. And there are some good diversion schemes already, and the DHSC and NHS England have got their community sentencing treatment requirement program. And if we can get that spread out across the country, again, these are things that allow us to use a more health approach to individuals who are not benefiting and are possibly made worse by a short prison sentence. And then, of course, the care of people as they leave prison if they have got a drug history. If you leave prison with your benefits not sorted out, no financial resources, your treatment not ready, fixed up, and you have no housing or employment, and all of those things are entirely possible, then your chances of surviving and not going back to your old habits are really hugely diminished. So a lot to do and work effectively with the criminal justice system and probation around prison sentencing. Recreational drugs, there's a little in this report on that, and you might say, why have we not given it more consideration? Well, we have very little research to help us. What we do know is that mass communication based on anti-drug messaging have been shown to be ineffective and can compound user attitudes and behavior, and therefore any campaign's got to be grounded in behavioral science. But we do know that the many people who take recreational drugs do not think they have a drug problem, do not think that they are indeed addicted. But we know that this fuels the market. And also, of course, there are risks to themselves depending on the drug they are taking. So we need a much better understanding of how we can influence behavior. I think this is an area that is ripe for research and then much more effective communication. So we've recommended an innovation fund, which could fund research into interventions that have as their end the hope of changing behavior. And I think very finally, as you will have seen in the report, we want more research in this area. It doesn't matter whether you look at the very practical research, let's say, around recovery, whether we think about those who are taking non-opioid drugs, wherever you look, we have a need for this to be taken much more seriously. The NDTMS is a valuable resource, and again, that could receive much more attention and be linked to other relevant databases. And that would create for us a wonderful drugs data warehouse. And the recommendations there are both to DHSC and to BEIS. So to end on what I hope is an optimistic note, I know we need this additional funding, but I hope that if we can make the real case to the Treasury in the spending review for this, what is on offer is a whole systems approach that brings people together, enables them to work together. And we think that based on all the analysis, over 5 years, for every pound invested, there would be an average saving of 3.5 in costs elsewhere. And you can see some of the gains, whether it be in opiate overdose deaths that are prevented, additional people, many more additional people in long-term recovery, and a whole wide range of impacts on reducing homicides, serious violence, people sleeping rough or losing their homes, etc. So I hope and look forward to the government's response, and would really love to see us start the journey to really make a difference to those who are dependent on drugs and at the moment really do not have a good service nor the chance of full recovery. So thank you very much. I'm going to stop there. And of course, look forward to the question and answer session.
Thanks very much, Dame Carol. and we're going to move on, and there's lots of questions coming in, so we're going to make sure we get as many of those questions to you at the end. It's a pleasure to introduce Rosanna O'Connor, next to speak, who's Public Health England's Interim Director for Health Improvement, previously the Director for Alcohol, Drugs and Tobacco within the Health and Wellbeing Directorate at PHE. Thank you very much. On to you, Rosanna. You're on mute. Going. Not quite got off yet. Frozen on mute. You able to help Peter or Oliver get Rosanna off mute if you can?
Rosanna, I'm not sure I can do it. I'm going to click ask to unmute, so it might be that something pops up on your screen.
Oh, nearly.
Okay.
Yeah, brilliant.
Fine. Sorry about that. I'm just going to go back to the slides. And I'm going to share the slides and hope that works. If you can tell me when you've got the slides shared on the screen, it would be useful.
Will do.
Okay.
It's not on yet. Not on yet. Just pause a minute. It's coming. Hopefully.
Are we there yet?
No slides on my screen. I don't know if you can see any, Oliver.
No.
No.
Right.
I can share from this end, Rosanna.
Please
Shall I do
that? Yes. Yeah. Looks like we may have a little bit of an operator error here. Okay.
Yeah. Can everyone see
Nearly
that?
there. Slideshow. Yeah.
Fine.
Great.
Okay. So thank you very much, and a particular thanks to Carol for today's presentation. And I just want to start with a slide that opens this part of the webinar up by talking to us all about seizing the opportunities that Carol's report provides. So a big thanks to Dame Carol, both for the first part of the review that was published at the beginning of last year, and then this second part. Probably the most impactful report that we're likely to have in the drug treatment and recovery space for some time. And a thank you to the Public Health England and the the Department of Health and Social Care team that supported the review. And of course to the field, everybody from the expert advisory group to other people who have engaged with Dame Carol along the way. And a particular thank you to those experts by experience who have shared their views. All really powerful stuff that helps make the report what it is. So I think as we see that the assessment of treatment captured in the report provides an important platform for change, I think it's important for us to acknowledge that there is continued hard work and commitment across the field, that there are pockets of really good practice, and that I think people have really gone over and above to successfully maintain services and provide support to people during the pandemic. So a big thank you for that. And then a recognition that across the country, we've been able to rapidly mobilize the response to the additional 80 million investment for this year. And without people working really hard to be able to do that, it would have been very difficult to get any investment from this 80 million underway. So thank you for that. And then I guess just to remind everybody that this is a pivotal moment, and it does provide a big opportunity for us. We're expecting an initial government response soon, and there'll be a further response, I imagine, around the spending review that's planned for the autumn. And Public Health England, Pete Birkinshaw, who most of you will know, and our team in PHE stand ready to support the implementation of the recommendations, and they'll be a real priority for us. And that this work will continue as we move across to the new Office for Health Promotion that will start from the beginning of October. And I think to say, from someone who's been around this agenda for quite some time, government engagement on this is high. It's very high. And PHE, for example, is supporting the establishment of the new cross-government drugs unit. This is one of Carol's recommendations, and is seen as a way of pulling the cross-government response together and challenging departments to stick with this agenda and to do their part in making the recommendations from the report come to fruition. And I guess just a really important point, particularly from my perspective, that system reform is as important as additional resources, and the two must work together. Just putting more money into the system as is won't really get the benefit we're after. This is as much about things being done differently at a local level and about strategic partnerships as it is about anything else. So just a little bit about the Office of Health Promotion. Chris Whitty won't be unfamiliar, I'm sure. And I just wanted everyone to know that all our drugs and alcohol functions from PHE, both national and regional functions, will transfer into the new Office for Health Promotion from October. That a new Deputy Chief Medical Officer and a DH Director General will jointly lead the office. And whilst organisational structures for the office are currently being consulted on with staff, we anticipate that the drug and alcohol work will be well placed in the new structure. So just a little bit of focus on the additional funding for drug treatment in this current year, which we remember came about by the pressure and the interest generated by Dame Carol's first report. So there's 80 million going to local authorities to fund drug treatment this year. That is in addition to the money already being spent by local authorities from the public health grant. It's the biggest increase in drug treatment funding for 15 years, so a long time. And it's very significant in the context of galvanizing cross-government interest across departments in looking forward to the next spending review. The majority of this 80 million is being spent via what we're calling a universal approach. And then there's there is a further 10 million that's being allocated to joint commissioning of inpatient detox services. And those of you who will know that the inpatient bespoke specific inpatient detox for people from drug and alcohol services has practically fallen away over the last few years. And we're really pleased that 15 consortia covering almost every local authority in England have been established and have agreed delivery plans, which are now being mobilised. Now, the timescales for planning and mobilisation of all this money have been demanding, but the engagement and buy-in from local authorities and services have been impressive. And here on the right-hand side of your screen, you'll see how some of that universal funding is being spent nationally. So 55% on improving pathways for criminal justice clients, 15% on naloxone, on outreach and on needle exchanges, and a substantial amount of additional funding going into residential rehab. So a big boost across the country. And to support that additional funding, we've got we've had our team at the centre added to provide support and support at a more local level. So that team is supporting the challenge of that 80 million uplift, and it will be promoting learning and expertise, providing topic leadership around medically managed inpatient detox particularly, and of course supporting local areas, either strengthening or setting up the criminal justice pathways that may no longer be in place. And of course, the overarching aim of this will be to promote Dame Carroll's report's recommendations from this review and from the first report. So part of the initiative that has flowed from the first report was the setting up of what have been called ADA areas. So we've got 5 of those areas across England and Wales, 4 in England, and we're about to have announced 8 additional ADA accelerator areas. And those bring together the Home Office and the Department of Health and Social Care and PHE interests. And the areas were selected based on the evidence of drug harm from various data resources, including drug-related deaths and unmet need. And the programme aims to reduce drug-related deaths, drug use and drug-related offending via a whole system approach. So it brings together criminal justice and health partners, and it's an attempt to join up the system. I think as many of us would have seen it joined up years ago, but it's trying to join up the enforcement, diversion, treatment and recovery interventions with enhanced employment and accommodation and support programs. And an additional influx of money into the system has been the money announced from MHCLG that provides a rough sleeping drug and alcohol grant focused on 43 local authority areas to improve drug and alcohol treatment services for people who are either sleeping rough or at risk of sleeping rough. And the support for that is provided through a series of guidance, webinars, and face-to-face support from national and regional PHE teams and the MHCLG rough sleeping advisors. So basically, there's a sort of cross-government initiative to work together to provide local areas particularly affected by rough sleeping, and a big thank you to providers and commissioners who are working hard to make this happen in pretty challenging times. And then Dame Carroll mentioned individual placement and support, which we refer to as IPS. And that there's been some further funding to support the work that comes out of the IPS alcohol and drug trial. The Department of Work and Pensions is investing a further 10.5 million to expand access. And we're looking to expand that to 45 local authority areas, which will cover 40% of those in structured treatment. So we'll be helping thousands of people a year to find employment. It will be adding to the evidence base for this approach, and it will be embedding the IPS with new providers across England. We're expecting the results of the IPS alcohol and drug trial to follow later this year, but this is a really, really valuable cornerstone to the recovery offer across the country. And then one of the areas that we're investing in, particularly in this current year, is improving the criminal justice pathways into drug treatment. So the focus will be on increasing the uptake of treatment for people who come out of prison with a need for continued treatment and support. So that referral pathway from prisons into community-based treatment, and then increasing the number of community sentence treatment requirements, particularly drug rehabilitation requirements for people who might need them. So more than 50%, as I said earlier, of that additional funding is going to be dedicated to this. And I think a reminder that in June this year, the probation services in England and Wales were unified to deliver enhanced support for prisoners through the gate and a more consistent approach to the management of offenders in community sentences. So we are expecting, and you should expect, much greater focus and much better support than has been in place in recent times for helping people coming out of prison or who might be at risk of a sentence, who have got a drug treatment need. And I think to help with this, it will be a useful reminder to those of you who will have had new police and crime commissioners elected this year. That election process changed the shape of who the police and crime commissioners are. You may well have new ones in your area, and the need to engage with them and help them understand the importance of this agenda, it will be very useful. We're looking at NHS reform at the same time as all these other changes are coming about. There was a white paper published earlier in the year, the integration and innovation working together to improve health and social care for all paper. Two particular proposals that are key to us all on this webinar today: a stronger duty to collaborate between the NHS, local authorities and the third sector. So really important expectations here. And also something that will be useful, I think, there's an expectation that that procurement will be much less bureaucratic and much more collaborative, and that the negative effects of repetitive retendering cycles on drug and alcohol treatment services will be improved. It was something that Dame Carol heard quite a bit about and has recommended that we review the effect of retendering on the quality and cost effectiveness of treatment services. So that is good news for all of you who have been through retendering services in the last few years. And we're expected integrated care systems to be of benefit. I think Carol has make strong points about how drug users should be able to expect from the NHS much better support than they currently have, both in helping with mental health issues, but also physical health issues. And we're hoping that the establishment of integrated care systems will go a long way to see a better approach to providing the needs for the needs of those with multiple and complex needs. So here we are. We all, every single one of us on this call, wherever we sit in the system, have a real and rare opportunity. We need to seize that moment. We need to build on the momentum generated by Dame Carol's review, and we need to unify the field to serve the interests of those that we're here for, those people that need good treatment and recovery opportunities. So we need to get our voices heard, and we need to make those messages stick. And in doing so, we need to harness, at whatever level we work at, we need to harness strategic partners at a local level, at a national level, because without ambition and without that leadership, we aren't going to be able to make all the recommendations that Carol has gone to such ends to provide for us. We aren't going to make them real, and we really all have a duty to play our part in getting that done. So a big thank you to all of you for both joining today, for helping with the review, and who will take these recommendations forward in your local level, wherever you play a part in the local system. So a big thank you once again from all of us in PHE. Thank you.
Great, thank you very much. So we're back now. We're into our question answer sessions, and there's been some great questions that have been typed in to both chat and Q&A. So we're trying to pull those together and come across some of the consistent themes that are coming through to cover as much as we can. So I will name check people where I can, where I've managed to keep the right note. But I guess one of these sort of themes, and I'll give Rosanna a pause for breath after being on last. She can come in next. Two questions for you. But the question to Dame Carol Black comes from Ian Gray and connects also Aaron from WDP. What are the chances you feel that the report will be listened to and implemented in full? And it connects to how well has the report been received by, I guess, government and those in power. Dame Carol, do you want to pick that up?
So, thank you. Can you hear me, Paul?
Yeah.
Good.
Yep.
I think it's fair to say well, and I think a lot of work was done beforehand. I mean, if you want to do a report like this, a whole systems report, you have to spend many months persuading 6 departments of state that they need to play with you in this space, and that it is important to them and they can make a really big difference. And if they're not with you, then it really is diminishing what you can do. So I think the first thing is, although it looks perhaps quite simple as written, to get those 6 departments of state in the report. They've all been deeply involved, and we've been meeting across government for several months now, working through all the agendas. We've had real interest and support, more than I've ever seen before, from Number 10. So the Prime Minister is deeply concerned about drugs. Of course, part of that concern is because of the homicide and the serious violence and the number of prison places that drug dependency uses up. But a real interest also in recreational drugs. I think by the fact that they've already announced a central drugs unit, it's being taken seriously. Can I say that every one of my 32 recommendations will receive the same, attention? Of course, I don't know, but I'm hoping that I will see them all welcomed. And of course, there are things that are so much more important to get on with, like get a central unit done, start to think about the national outcomes framework, all the work that HEE needs to do, the work that needs to be done locally. I think, as Rosanna has said, if not now, when? Because there is no better bringing together of interest, concern, and determination. The other thing, and of course it's by happen chance, that the man who commissioned part 1 of the review, Sajid Javid, when he was in the Home Office and was deeply interested in this area, commissioned part 1, is of course now the Secretary of State for Health. And I think we will find that he is deeply concerned about this area and really wants to make a difference. I know he's got loads of other things on his plate, but I think there's not a better time. But as Rosanna's just said, it requires everybody else now to come to the party and to make sure that this topic doesn't just sink below the parapets again, because that's where it was when I started 2 years ago.
Thank you. So the next question we've got in, I'll start with Rosanna and then Dame Carol. We're on to both of you can contribute if you want. We've got lots of questions, but I guess there are some sort of key themes coming through both inside this webinar and outside of it. But one of the questions, which is summed up by somebody, is assuming the comprehensive spending review positively aligns with your recommendations, we start to consider moving forwards. I feel it's important to consider how we got here and how we as a sector prevent the current situation occurring again. So if we start with you, Rosanna, in your assessment, what are the lessons learned or that we need to learn as a sector so that we make sure that history does not repeat itself?
Thank you. Thanks. Well, I think one of the things that's useful as a starting point is that undoubtedly Dame Carol, in her leadership of these 2 reviews, opens doors in a way that hasn't happened for a long time. And one of the things I guess that we shouldn't lose sight of is that the report, this one and the first one, highlight the way in which at a local level the partnerships that used to be in place that supported commissioning had an interest in the way in which the money was being spent and in the outcomes that money was producing. If we can get those strategic partnerships back in place, so that the outcomes of treatment and recovery services matter to everybody, we will be in a much better place than we are now, if in fact money starts to be scarce again. I think that bit of system reform is really, really important, and I think it goes a long way to reduce the problems that we find, the problematic situation we find ourselves in now. And those partnerships are reflected across government now, as Dame Carol has said. The representatives from those departments meet regularly now, and there's a really strong sense of collegiate activity and support going into the next SR. It may not all come off, and it may not all come off at once, but if we can get that approach mirrored at a local level, we'll be on the right path.
Thank you. Did you want to add, Dame Carol?
Well, could I ask that Pete be asked, because he's been in this space for so long, and where he will have seen, many years ago and what has happened, and I'm sure we'll have some real reflections that none of the rest of us have.
Are you there, Pete?
He is.
Yes.
Sorry, the hardest question that Carol, you've pulled me in on. I mean, it's a difficult one, isn't it? I think one of the things we've really got to work on as a field is about how we kind of unite and have a clear and shared voice. There are, lots of different approaches to this problem and factions within the field, and I think one of the things that we have suffered from historically is not having a clear, single, coherent voice on really big and significant priorities. And sometimes some of the sort of factions within the field have got in the way. We've allowed that to get in the way, really. I hate to keep quoting it, but I do just like it so much, is someone once described working in this field as circling the wagons and then shooting in. And we've got to get better at shooting out and connecting to the politicians and getting our voice to cut through. I think that's a really important thing going forward.
And Paul, I just to that, you'll see there is a recommendation. We haven't got the shape of it right yet, but I wanted a centre, a place where anyone who worked in addiction could actually start to come together professionally. You
Mm.
start to build a really strong, and as Pete says, united, not fragmented, community who will support each other and will be there when, if things start to go wrong, to really raise the issues very early on, but as a united group, whether they're people who are working in recovery or people who are doing detoxification. I saw it as a place to bring some solidarity together, and I absolutely agree with what Rosanna said. I think if there was if a needs assessment was done jointly and commissioning was done jointly, where people start to really work together, and we know that can work. There's still good examples of it, even though there's been less resources. So but it does require people sort of not wanting to fight each other and have their own little agendas.
Thank you. I'm just going to move into another area quickly where I get that. As it comes up, and both of you may want to comment or not on this, but it has come up as a question in this webinar. Because you started, Dame Carol, by saying that there weren't going to be any legislation changes. And I think then people have gone to, well, what would you have suggested if you didn't have that template? What would be different?
Well, I'm not going to answer that question,
okay,
actually, because I seriously haven't gone and looked at any of the evidence of that. But I would say we have got so much to do that we can do now that will make a difference. That we should just jolly well get on with this. We can start to really make an inroad on the 300,000 opiate and crack users who just need so much help. We can start to make a difference on providing central leadership and really bringing together people locally. I didn't feel, I know people have said to me, well, didn't you feel your hands were tied behind your back? Quite frankly, no. I think I had more than enough that is wrong, that needs attention, and that can be done now without any legislative change. So I didn't feel deprived. If people think I felt I wasn't given a good deal, in fact, they're wrong. I felt that I was allowed to look at some really difficult problems and come up with a whole systems review.
Thank you. I'll ask a next question, and Rosanna, we'll go to you with this first. This is from Dave Target. Do you feel that given the announcement from central government that the minister with responsibility for the new unit and workflow will be in crime and policing as opposed to health, substance misuse treatment is being placed in the correct context? So I guess, Rosanna, do you want to kick off?
The fact that it has, the fact that there is a minister who has been given a specific responsibility for drugs is good. It's a minister who has a real interest in this area. It's a minister who has got the ear of the Prime Minister, and the minister happens to sit in the Home Office, which is the department over the years that has kept money tied into the treatment system. So I'm not overly worried about that. The joint drugs unit is owned across government. We have provided staff for that unit. We'll be taking a really keen interest in how that unit works. And the point of it is that it holds departments across government accountable for what they're doing on this agenda. I would just say I'm not overly worried for all the reasons that I've just stated. Sorry if that disappoints the person who's asked the question, but a bit as Carol has said when she answered the previous one, we have to work with what we've got. Let's just get on with it. You know, we can make a difference, and we can work with anybody who is willing to really step up to this agenda And we'll be doing exactly that with the minister with responsibility for this. So just keen to get going, actually.
Okay, thank you. I'll move on to the next question, which I guess there's a lot of questions that are coming up really about we're moving from the current position to something which is ambitious and quite challenging, and it's what support will these areas get. So Desley Dennis has asked a question which welcomes, obviously, as a lot of people have, the recommendations review, really pleased. It is contingent on having skilled staff, and I can tell you, having worked across the country, it's not just London, but London has many challenges. Is this acknowledged by the sector? And is there any work being planned on the skills gap?
I mean, at least I could start, but then I think maybe either Pete or Rosanna would come on here. We absolutely acknowledge the skills gap, and there is an urgent requirement, as you'll see in the review, that Health Education England work pretty efficiently and quickly with a DHSC to come up with a workforce strategy. Now, some of the things you need, as you will well know, will take a long time to train. I mean, some of the actual, you know, if you're thinking in terms of doctors or psychiatrists, it's a very long time. But there may be people who, if they thought that this was really receiving funding and it was really going in the right direction, would come back into addiction, because many people have left it. For psychologists, we've got a broader church and that it's not such a long training, and we could do very well with thinking about those young people who are just getting their qualifications in psychology. So I think it's horses for courses. There is some things that will need new training systems perhaps, or additional things, but I think we're absolutely aware, as I said from my figures, that we just do not have the workforce to do it at the moment. And that is why I think if you think that we've suggested money goes in over 5 years, we recognize that we've got to be building and building securely and slowly. We can't go from 0 to 100% all singing, all dancing service. But Peter, I don't know whether Peter or Rosanna wants to say anything more, but we've thought a lot about the workforce.
Pete?
I mean, there's not. I mean, just to agree that it's a long and as Carol said, you know, this is a long-term endeavour. We're not going to turn this around overnight. And I think whatever we do in the short term, there's also got to be much longer-term planning. You know, 5-10 years is really the sort of horizon that we need to be looking at to get this completely right. But there aren't going to be short and quick answers, but we need to have that longer-term vision with a much longer term workforce strategy. And also picking up on one of the other questions, that in the kind of the modelling that we've done and the expansion of the system, we've also built into that increases in commissioner capacity as well, because we think that that's sorely needed, particularly in some areas where there's a very acute shortage of commissioning capacity and perhaps in some areas competence as well.
Thank you. Yeah, if you stay on, it does connect to, I was going to ask you that question, because we've got the longer term issue. Obviously, I guess a lot of providers, areas are struggling with the short term requirements of finding a lot of people to fill roles in the short term. So I guess it's this chicken and egg thing.
Also, Paul, just to say, you know that the NHS has had 2.3 billion, I think it is, isn't it, in the long term plan for mental health. I mean, we need to put some pressure on our colleagues. I mean, it would be very nice. That is, a lot of that is for community mental health services. Wouldn't it be appropriate if some of that was earmarked for our population? So I think it's we just need to be as innovative as we can and try very hard to start to put the right building blocks in place, and I think if we had the right financial resources, and as I say, I think we would find some people who think it worth coming back into the system.
Great, thank you. I was just going to ask, as Pete Birkinshaw was talking about that. There is a call for this from Mark Knight from Greater Manchester Commissioning, call for greater emphasis on commissioning and joint planning to direct spend from 22-23, which is most welcome. And there's concern that there's not enough strategic capacity in local authority public health departments to do this in the lead up. Is there something that can be done to encourage departments of health to invest in planning for this more immediately? So I just wanted to pick up that point you raised, Pete, whether there are any particular plans for that. Where is it? Rosanna?
Well, I think I said it in the modelling that we've done. We built in increasing commissioning capacity, so we would expect some local areas to use some of the additional resource if we're successful on increasing their strategic and commissioning capacity within local authorities.
Yeah, and I think just to add, Paul, we'll be socialising the report with all the key stakeholders, so directors of public health, local authority leaders, directors of adult services, and this need to invest in and make sure you have appropriate commissioning staff in any local authority is absolutely key to any locality being able to make the best of these funding opportunities. So you needed to be absolutely on the front foot if you were going to be in a position to be able to make use of the 80 million this year. And places will miss out if they aren't able to grasp those opportunities or be in a position to make the best use of them for their population. So it is beholden on local authorities to ensure that they have the right staff in whatever positions across the authority. And we'll be making that point when we engage with the Association of Directors of Public Health and others about the report. Yeah.
Thank you. Thanks very much. I guess the other areas which are there are come to Rosanna's point around whether, I mean, most areas have average caseloads, most staff between 50 and 80, some as many as 120, and you were saying 30 to 35. So there is this issue around, as Rosanna said, you can't throw the money back into the system. You need to develop more, and a lot of questions have come in around how priority areas that aren't getting enough investment, Black and minority ethnic groups, recovery organisations, how are they going to get the investment required to deliver, as well as meeting some of the shortfall in investment that's been taken out? Does that make sense, that question?
Yes, I mean, I'll give just I'm sure Peter and Rosanna can give a more exact question, but what I was hoping was that if there is increased funding going to a local area, let's say, that you will only know when you've done a really good needs assessment, you know, how much of that resource needs to go to particularly vulnerable groups, let's say a BAME group. That won't be the same in Cornwall necessarily as in the middle of Birmingham. So that I was saying there will be a variable needs assessment in the different parts of the country. And then you need people capable and able to then start to put together a service that meets that need. And of course, I'm aware you may not be able to do all of the needs, but I often, my impression as I've done this work is that often people were not able to do the need assessment they needed to do to even know sort of what was in their population, that they just were so stretched. And so for me, it would be really giving them that capability to sort of work out what is needed and then try to match your interventions to that. But and as I said, we did feel strongly about PS support workers, and Ed Day again will be doing a lot more work to sort of flush that out. But don't know, Peter or Rosanna, whether you want to add to that.
I just add quickly that one of the things we had to do, Paul, was consider what could be done with 1 year funding when we had a sniff that this 80 million might have been available. So there was no point in us asking for local areas to do things that needed lots of run-in time, lots of local consideration, lots of planning. We needed to be ready, able for this to be delivered in 1 year. That's why we've approached the 80 million like we have. I think the other thing is that local authorities need to be ready. They need to absolutely know their population. There is no excuse for not knowing the needs of their most vulnerable populations. It's the only way they'll do anything to reduce inequalities or to address the levelling up agenda. They need to know what those populations look like and what they need, and they need to be ready. This agenda is going up. This agenda is going up the political agenda, and people will miss out, I think, if they're not on the front foot. So it's, as ever, it's important to know your population and be ready to be able to respond.
Thank you.
Pete, did you want to add to that?
Did you want to come in?
I think you've covered it. I mean, I firmly believe, and I know that you do as well, Rosanna and Dame Carol, that local areas are the ones who can get this right. What we need to do nationally is create the environment where they can really get into all the corners and understand all the diverse groups and different populations and design targeted and tailored services. But we need to create the platform for them to have the space to do that. And that's the balancing act. And we need to get, but we can make a terrible mess of things nationally. But what we've got to do is create the right environments locally, and that's where the diverse needs and all the different minorities, that's where it works. But we need to create the space and the environment for that to thrive.
Thank you. So a couple more questions. We got getting through the questions, keeping you on your toes. Hopefully, some of the questions that are coming from people. I suppose a good question to ask. Lucy Holmes has asked this from Alcohol Change. With regard to the financial recommendations, an extra 552 million over 5 years, do you feel this adequately accounts for alcohol need too, or must we continue to call for yet more on top of the 552 million if alcohol treatment is also to be fully supported?
I think, but Pete will correct me, or Rosanna will correct me, that when John was doing the analysis, that for the SR bid, that alcohol was taken into account, Peter, but please correct me if I'm wrong.
Yeah, and just to clarify, it's not 552 over 5 years, it's 552 in the 5th year.
In the 5th, yeah, that's right.
Yeah.
Yeah.
So it's 119 first year, then it goes up to sort of 300, and by the 5th year, it's 552.
Yeah, we were very aware, Paul, that the political interest was in drugs, and that most drug services, most substance misuse services at a local level are commissioned for providers to provide drug and alcohol services, and we wanted to make sure that the system at a local level wasn't disjointed. So we took into account the needs of services universally across drugs and alcohol as part of this work, needing to make sure that we didn't leave the alcohol needs behind as this was crafted.
Thank you. I guess the most important of the other questions to ask, I think, which has come through as a flavour, is a question around family work and broader work with families. Could you add any more to what's already in the report as to how you envisage this? Because I think people are generally a bit concerned. There's not enough in it in terms of meat. Who wants to start? Sorry, I'm not sharing very well because you've jumped in so far.
I mean, we certainly discussed, as well as vulnerable groups, very much. We discussed family groups and particularly young people in the context of families. But I wouldn't say that we have been at all prescriptive in any way about that. But you know, there were a huge number of issues that we considered.
Thank you. Rosanna and Pete, did you want to add any more to that? I know we're at the tail end, but is there anything that you feel? Go on, Rosanna.
I was going to suggest that Pete does. He was closer to this part of it than I was.
I mean, there is reference to I presume the questions are focusing on support to family members in their own right. There is reference to it in the draft Commission Equality Standard. The other thing that I would say is that we've been quite clear and are quite committed that anything like that and the local outcomes framework are developed in consultation with the field. So people shouldn't see this as the end result. Some of these things are going to need to be developed in the longer term with engagement and consultation in the field. So, you know, hopefully you'll keep us on our toes in relation to those issues as that's done.
Okay, just as we come towards the end of the session and looking at all the questions that have come in, and is there any sort of final comments you'd want to give to prompt us on in terms of how we successfully, because I think generally people are really positive about the work you've done, and thank you all of you for the work you're doing and have done, and are excited about it. But is there any final comments from you before we close the session? Dame Carol, do you want to go first?
I think probably the only thing I would say is please don't sort of give up if it doesn't all happen immediately in one big scoop, because I think this is a journey and that we need to do it in that way. We didn't get into this place overnight, and therefore we need, you know, to work together to get out of it. But I am sure that we absolutely need the investment from the Treasury in order to be able to do most, not all, but most of the things that are in the report. Of course, things like I'd love to hear more people talk about drug dependency as a chronic condition. I'd love to see that the stigmatization that reduced, and I think that's partly the way we talk about it and the culture around it, and that is in our gift now. And when people say to me, but you can't do that under the present legislation, you can. There's nothing to stop you treating drug addiction as a chronic condition with remissions and relapses, and parity of care with the NHS. So I'm in there for the long haul. I shall cover my feet, keep their feet to the fire. Do not think I'm going away. Having put 2.5 years of work into this, they know that. So I shall probably be digging away, making sure things are happening and we're making progress.
Thank you, Rosanna.
I would just say own it. You know, this report is for all of us. Own it and do what you can and have your ambitions high.
Great, thank you. And thank you for your contributions, all of you, this afternoon. And thank you for everybody who's attended. I leave the session really excited about the future, and also, you know, really feel that sort of sense of commitment and energy that comes from this, and responsibility as well. I'd also, just before we go, like to thank Oliver Standing and Peter Keeling from Collective Voice for supporting this, as well as the panelists. And I hope you've enjoyed the session, and there'll be more to come. We've got a lot of work to do over the long haul.
And now as well.
And now as well. All right. Yeah. Keep me to that. All right. Thanks.
Take care.
Everybody.
Thank you very much. I enjoyed it.